Welcome back to the Culture of Healthcare, Quality Measurement and Improvement. This is part two of our series. As a reminder, this component, the Culture of Healthcare, is a design to help you understand the expectations of working in healthcare settings. And we've been exploring how care is organized within practice environments, the importance of privacy laws, and the professional and ethical issues that shape every day. In part one, we introduced the foundations of quality, what it means, how it's defined, and the frameworks we use to measure it. In this section, we'll take a closer look at how those measures are applied in practice and what they reveal about the state of healthcare in the United States. For clinical engineers, this means thinking about quality not just in abstract terms, but in how devices, systems, and data actually support or sometimes limit the ability to deliver high quality care. So let's dive in. Quality measurement and improvement. Let's go and look at the objectives for this session. And we're going to be focusing on objective three. Discuss quality measures used in various healthcare settings in the United States, including those required for high-tech meaningful use program. So meaningful use under the HITECH Act requires hospitals and clinics to adopt electronic health records, EHRs, and demonstrate their use to improve patient care. And for clinical engineers, this meant ensuring that medical devices integrate with EHRs to provide accurate real-time data, supporting quality metrics such as medication safety, infection control, and device utilization, helping measure and report quality through automated data collection from imaging systems, monitors, and lab devices. So let's go ahead and get started. Quality measures and the HITECH Act. In this session, we're going to look at quality measures currently used under the meaningful use requirements of the Health Information Technology for Economic and Clinical Health Act, better known as the HITECH Act. On the slide, you'll see a sampling of the quality programs and measures in use today. As Don Berwick, one of the leading voices in healthcare quality, has pointed out, we are still early in the science of quality improvement. But what exactly does that mean? The Institute of Medicine describes this science as a framework for assessing and improving healthcare quality. Over the years, many different measures have been developed, each reflecting a slightly different perspective. Almost like competing standards, the Agency for Healthcare Research and Quality, or the AHRQ, helps us make sense of this by maintaining a clearinghouse of available measures, what they are, where they are used, and how they apply. But even with all of these measures, there's a growing consensus we need standardized sets. Without them, every organization is measuring quality in a different way, making it nearly impossible to compare performance or capture the full value of improved efforts. In the following slides, we'll break this down further. We'll explore specific quality measures from three different perspectives: health plans, outpatient medicine, and inpatient medicine. And we'll close by looking at the quality measures required under the meaningful use rules of the HITECH Act. For clinical engineers, this is where the technical side of healthcare quality really comes into focus. Meaningful use depends heavily on the integration of health IT with medical devices, and engineers are at the center of making sure those systems deliver accurate, reliable data to support these quality measures. So let's take a closer look at how quality measurement is being put into practice and how technology plays a role in shaping the science of improvement. Health plans and HEDIS. So the first perspective we're going to look at is health plans. Why start here? Well, health plans have a historic role in quality improvement. They were among the first to systematically measure quality, at least as process measures, and to actually act on what they found. In many ways, they were pioneers and they deserve credit for helping launch the movement toward accountability in healthcare. One of the most important tools they developed is called HEDIS, which stands for the Health Plan Employer Data and Information Set. It was created by the National Committee for Quality Assurance, or the NCQA. So HEDIS includes around 60 measures, most of them focused on healthcare processes. These measures are used to evaluate health plans, especially health maintenance organizations, or HMOs, and they cover a wide range of common high impact health issues. For example, HEDIS measures look at things like asthma medication use, whether patients stay on beta blockers after a heart attack, how well high blood pressure is controlled, comprehensive diabetes care, breast cancer screening, management of antidepressant medication, immunization status, and whether smokers are being advised to quit. And here's the scale of it: more than 90% of health plans in the United States use HEDIS. It's become the industry standard for assessing performance. Now, NCQA doesn't just stop at measuring processes. Their reports go further, calculating lives saved when organizations follow these process measures and translate them into better outcomes. And for clinical engineers, the connection might not be obvious at first, but think about it. Many HEDIS measures depend on accurate testing, reliable devices, and smooth data transfer. So, for example, blood pressure control requires accurate blood pressure monitors. Diabetes care requires lab results that integrate seamlessly into the patient's record. Screening for cancer or immunization status depends on reliable reporting systems. Engineers play a behind the scenes role in making sure that the data health plans rely on is real, that it's accurate and trustworthy. So while health plans might be the pioneers of quality measurement, clinical engineers help make sure those measurements reflect reality and ultimately that they translate into better outcomes for patients. Categories of HEDIS measures. Let's take a closer look at the structure of HEDIS because it's not just one big scorecard. It's actually made up of categories, and each category has specific measures. One important category is effectiveness of care. This is where you'll find measures like childhood and adult immunization rates, whether patients stay on beta blockers after a heart attack, screening rates for different types of cancer, and a cluster of measures around chronic diseases, especially diabetes. And these effectiveness of care measures are designed to answer a basic question: did patients actually get evidence based services that are known to improve outcomes? Another category is access and availability of care. These measures look at whether patients can actually get the care they need. Are preventive services available? How easy is it to see a primary care provider? And how early is prenatal care initiated after expectant mothers? These measures get at the idea that care can only be high quality if patients can actually access it. A third category is about satisfaction with care. Here, we're talking about member surveys, what patients think about their care, and the tracking of how often preventive services are used. It's not just about clinical outcomes, but also about the patient experience. Together, these categories give health plans a broad view: effectiveness, access, and satisfaction. And because HEDIS is standardized, health plans can compare themselves to other health plans. That's where the benchmarking piece comes in. From a clinical engineering perspective, these categories may seem far removed, but they actually depend on technology at multiple points. Childhood immunization rates, for instance, require accurate EHR documentation and reliable vaccine storage equipment. Access and availability measures depends on telehealth systems that connect patients to providers. Patient satisfaction surveys often capture feedback about wait times for imaging, delays from equipment downtime, or even the usability of patient portals. So while HEDIS measures are focused at the level of health plans, the ability to meet those standards is built on a foundation of safe, reliable, and accessible technology. And that's the part clinical engineers help guarantee. Outpatient quality reporting. So, what about quality reporting in the outpatient setting? In the United States, the main efforts here have been led by the Centers for Medicare and Medicaid Services, or as you know it, CMS, especially within the Medicare program. One of the biggest initiatives was the Physician Quality Reporting System, or the PQRS. This started out as the Physician Quality Reporting Initiative, but over time it evolved into a broader, more structured program. In its early years, PQRS offered physicians who participated in Medicare a 1% reimbursement bonus for reporting on quality measures, and there were a lot of them. By 2011, there were 194 different measures that physicians could report on. On top of that, physicians could get another 0.5% bonus for maintaining their certification in their specialty. But by 2015, things changed. Instead of paying bonuses to encourage participation, CMS began applying payment reductions for providers who failed to meet the reporting objectives. In other words, it shifted from carrot to stick. Another program was the Electronic Prescribing Incentive Program, or the ERX. So, like PQRS, this started with a bonus payment, an extra 1% reimbursement for physicians who adopted electronic prescribing. But by 2012, the bonus expired and payment reductions kicked in for providers who didn't meet the program standards. What these programs show us is a pattern. CMS uses financial incentives, both positive and negative, to encourage outpatient providers to adopt quality reporting and health IT. For clinical engineers, these outpatient programs matter because much of the reporting depends on accurate technology integration. PQRS relies on data flowing correctly from EHRs, lab systems, and even diagnostic devices in outpatient clinics. And the ERX program, the electronic prescription program, depends on secure, reliable prescribing systems that connect pharmacies, physicians, and patient records. When these systems aren't integrated or maintained properly, providers risk losing reimbursement not because they didn't deliver good care, but because the data didn't line up. So, in outpatient quality reporting, just like in inpatient care, technology is the bridge between what providers do and what gets measured. And it's clinical engineers who make sure that bridge doesn't collapse. QRS quality measures. Let's take a closer look at what kinds of quality measures are actually used under the Physician Quality Reporting System, or the PQRS. These measures weren't abstract, they were tied to real conditions that providers manage every day. For example, in diabetes mellitus, one PQRS measure looked at the percentage of patients between ages 18 and 75 whose most recent blood test showed a hemoglobin A1C level greater than 9.0%. That's a way to identify patients with poorly controlled diabetes. Tracking this helps highlight gaps in care and makes it easier to target interventions. Another measure applied to patients undergoing thoracic surgery for lung or esophageal cancer. Here, the quality measure was the percentage of surgical patients aged 18 and older who had clinical TNM staging done right before surgery. And TNM, tumor node metastasis, is a system that describes the extent of cancer in the body. Getting this staging done prior to surgery is critical for planning treatment, and measuring it helps ensure patients aren't rushed into surgery without full evaluation. And for children and adolescents, one measure looked at weight assessment and counseling. Specifically, it tracked the percentage of children ages 2 to 18 whose weight was classified based on their BMI percentile for age and gender. This ensures pediatric providers are consistently assessing growth and offering counseling when needed. Now, where do clinical engineers fit in? These measures depend on accurate technology and reliable data. For diabetes, that means lab systems and point of care devices have to produce valid hemoglobin A1C results. For thoracic surgery, imaging systems and pathology reports must integrate seamlessly into the electronic health record, so TNM staging is documented correctly. For pediatrics, BMI data depends on scales and height measurement tools that are calibrated properly, and EHR systems that automatically calculate percentiles. So PQRS measures don't just evaluate physicians, they also depend on the engineering and technology infrastructure that makes those measurements accurate and accessible. Without that backbone, the quality scores, they wouldn't mean much. In patient quality measures. So far, we've talked about quality reporting in outpatient settings. But what about hospitals? What about the inpatient side of care? Much of this activity is coordinated by the Hospital Quality Alliance, or the HQA. Now, HQA isn't a single organization. It's actually a collaboration that includes CMS, and the Joint Commission, um, and several others. Together, they developed a starter set of quality measures for hospitals. These measures initially focused on a few core conditions: acute myocardial infarction, heart attack, heart failure, pneumonia, and hip and knee replacements. One of the most visible outcomes of this effort is the Hospital Compare Project. This is a public facing website where hospitals voluntarily submit their quality data, and anyone, patients, families, and employers, can go online and compare hospitals side by side. The project really has two parts. The first is the Inpatient Quality Reporting Program, or the IQR. And this is where hospitals submit data on those core measures. And participation is an option if you want full payment. Hospitals that don't participate uh, face a 2% reduction in their Medicare reimbursement. That financial penalty creates a strong incentive to get involved. The second part of the project is about patient satisfaction. Here, hospitals use a standardized survey called HCAHPS, short for Hospital Consumer Assessment of Healthcare Providers and Systems. And this survey asks patients directly about their experiences, communication with doctors and nurses, cleanliness, quietness, pain management, and the overall satisfaction. It doesn't measure process quality, but it adds an important perspective: how patients themselves feel about their own care. Now, for clinical engineers, both of these dimensions matter. On the process side, many of the quality measures, like timely imaging for pneumonia or safe surgical practices for joint replacement, they depend on reliable medical technology. If a CT scanner is down or an OR device isn't functioning properly, the hospital risks failing those quality benchmarks. On the patient satisfaction side, technology plays a role too. Alarms that are too loud, equipment that malfunctions during a stay, or delays caused by broken devices can all affect how patients rate their experience. So, inpatient quality reporting is not just about clinicians, it's also about the systems and technologies that surround them. And clinical engineers are part of ensuring hospitals perform well on both the process and the patient experience sides of quality. HQA categories and measures. Let's dig a little deeper into the categories of quality measures reported to the Hospital Quality Alliance, or the HQA, and posted on the Hospital Compare website. So these measures are mostly process measures, the steps hospitals take to deliver evidence based care. The categories cover several core areas: myocardial infarction, heart failure, pneumonia, surgical infection prevention, surgical infection prevention, and children's asthma care. So, for myocardial infarction or heart attack measures, these include whether patients are given aspirin on arrival, whether they're discharged with the right medications, and inpatient mortality rates. These measures capture both process and outcome. For heart failure, hospitals report whether patients receive discharge instructions and whether their left ventricular systolic function is elevated. These steps are key for preventing readmissions and guiding treatment. For pneumonia, the measures include how quickly blood cultures are taken, how soon antibiotics are administered, and whether patients receive vaccinations for pneumococcus and influenza. The surgical infection prevention focuses on whether patients receive the right prophylactic antibiotics at the right time and whether they receive prophylaxis for deep venous thrombosis to prevent dangerous blood clots after surgery. And finally, for children's asthma care, the measures include whether hospitalized kids receive reliever medication when they need it and whether a home management plan of care document is created before discharge. Now, what's important here is that these measures are public. Anyone can go online, compare hospitals, and see how they're doing in these areas. And once again, clinical engineering plays a role in the background. For example, making sure blood culture analyzers and lab equipment are reliable is essential for pneumonia measures. Cardiac imaging systems have to be calibrated for accurate evaluation of heart functions. Surgical infection prevention depends on sterilization equipment working correctly and on real time monitoring systems that track antibiotic timing. Even in pediatric asthma care, devices like inhaler delivery systems and monitoring equipment have to perform reliably. So, while these measures look like they're all about clinical decisions, in reality, they're also supported by the technology infrastructure that clinical engineers keep safe, functional, and accurate. Non Medicare quality initiatives in inpatient care. Not all inpatient quality initiatives are tied to Medicare reimbursement. Some of the longest standing programs come from professional organizations. And one example is the National Surgical Quality Improvement Program, or the NSQIP. NSQIP. And this program is led by the American College of Surgeons and focuses specifically on the quality of surgical care. What makes NSQIP powerful is that it doesn't just measure raw outcomes, it uses risk adjustment to account for differences in inpatient populations. That way, hospitals can fairly compare their results and identify where improvements are needed. For academic medical centers, another initiative is the University Health System Consortium, or the UHC. Now, UHC is all about benchmarking. Academic centers submit their data to UHC, and in return, they receive detailed reports comparing their performance to peers. Many of you may have seen these reports with the familiar green and red dots, where green represents positive deviations from the standard and red represents negative deviations. Sometimes there's a half dot, sometimes two dots, but the idea is the same, a quick visual cue about where the organization is doing well and where it's falling short. Now, for clinical engineers, these initiatives matter too. Surgical quality, for example, depends on technologies like anesthesia machines, surgical monitors, sterilization systems, and even operating room robotics. If those systems aren't reliable, outcomes can be compromised, no matter how skilled the surgeon. And for academic medical centers where innovation and complexity are high, benchmarking helps ensure that engineering support is keeping pace with cutting edge clinical care. So, whether it's NSQIP measuring surgical quality or UHC benchmarking academic performance, these initiatives reinforce the same idea: continuous measurement, continuous comparison, continuous improvement, and behind the scenes technology reliability is a big part of making those green dots possible. High tech and meaningful use. So let's turn now to the High Tech Act and its meaningful use rules. And these rules were built around five national healthcare goals, and one of the most important was improving quality, safety, and efficiency. For both eligible professionals and eligible hospitals, the core idea was this: by adopting and meaningfully using certified electronic health record technology, the U.S. healthcare system would see major gains. The ultimate goal, as stated in the program, was that meaningful use compliance would lead to better clinical outcomes, improved population health outcomes, greater transparency and efficiency, empowered individuals, and more robust research data on health systems. Now, who could participate? Eligible professionals or providers could join the program under either Medicare or Medicaid, but not both. Quick refresher: Medicare is the federal insurance program for people 65 and older, some younger people with disabilities, and those with end stage renal diseases. Medicaid is a joint federal state program for low income individuals and families, including coverage for long term care, because its state run Medicaid programs vary significantly across the country. The Meaningful Use Framework was designed to roll out in stages. It launched in 2010 with objectives evolving over time. Each stage added more requirements, pushing providers to go from just adopting EHRs to using them in ways that actually transform care. And over the years, there have been ongoing discussions about shifting or even ending the program, especially with the arrival of MACRA, which we'll talk about later. Under meaningful use, providers and hospitals had to report clinical quality measures, or CQMs, selected by CMS, and they could only do that by using certified EHR technology. That means that the EHR system had to be officially certified for the specific stage of reporting. Providers had to follow detailed timelines, use the right version of their certified system, and submit their quality data to CMS in order to successfully participate in the incentive programs. For clinical engineers, this mattered a lot. Meaningful use wasn't just about software, it was about making sure medical devices, lab systems, and imaging equipment could connect securely and accurately to certified EHRs. If the data from those devices didn't integrate properly, hospitals risked losing incentive payments or even facing penalties. Engineers also had to keep track of EHR certification updates and make sure connected systems stayed compatible. So, meaningful use wasn't just a policy, it was a technical framework that reshaped how hospitals thought about data, how they thought about interoperability and quality, and it set the stage for the next big wave of reforms, including MACRA. On the next slides coming up, we'll break down the CQM reporting requirements in more detail and looking at the different options providers had as the program evolved. Now let's look at the 2016 CQM objectives. Now I know this is nearly 10 years ago, but it's a good place to start. So, as part of the Meaningful Use program, providers had to report on very specific objectives tied to clinical quality measures, or CQM. So, in 2016, the rules required eligible professionals, that's physicians and other clinicians, to report on 10 objectives. Eligible hospitals had to report on 9. And the difference, physicians had an extra objective about secure messaging with patients. Otherwise, the objectives were essentially the same, with only small adjustments depending on whether they applied to doctors and clinics or hospital organizations. So let's look at a couple of examples. Objective 1 for both groups was protect patient health information. To meet this, providers and hospitals had to conduct or review a security risk analysis, and this is critical for making sure patient data is protected from breaches, tampering, or unauthorized access. Objective 2 was clinical decision support. There were two parts to this. First, providers had to implement 5 clinical decision support interventions that related to high priority health conditions. And this could be things like prompts for diabetes screening, reminders for vaccinations, or alerts for heart failure management. Second, they had to enable and use functionality that checked for drug drug interactions and drug allergy interactions throughout the entire reporting period. Now, there was some flexibility here. For example, physicians who wrote fewer than 100 medication orders in a reporting period were exempt from the drug interaction check requirement. So, what does all of this mean for clinical engineers? Well, both of these objectives, protecting patient information and enabling decision support, depend heavily on technology infrastructure. The security risk analysis includes not just EHR software, but also the connected medical devices, network imaging system, the data sharing platforms that engineers are responsible for and responsible for securing. Also, the decision support depends on clean, accurate, real-time data flowing in from lab systems, monitors, and devices. If the data is wrong, the decision support tools will give misleading advice, putting patients at risk. So, even though these objectives were written for physicians and hospitals, the ability to meet them rests in part on the work of clinical engineers, ensuring that the data systems and devices are reliable, secure, and interoperable. Now, before some of you worry about physicians who prescribe less than 100 uh, prescriptions in a period, uh, don't worry. There's always backup systems in pharmacy. I've had to do that many times and look at drug-drug interactions where the system actually does it for you. So again, there's always a place where these things can get caught if they're missed in one particular place. Redundancy, I think, is what I probably just should have said. Clinical quality measures for meaningful use. So on this slide, we see the links to the 2016 list of CQM measures for eligible professionals, physicians, And we see the 2016 list for CQM measures for eligible hospitals and critical access hospitals and where that's located. Example, CQM measure. Now, the complete list of clinical quality measures, or CQMs, for both eligible professionals and eligible hospitals is far too long to display in one lecture. But let's walk through one example measure to see how the program works in practice. So this one focuses on children with pharyngitis, better known as a sore throat. Each quality measure is formally identified with a CMS eMeasure ID number and often a corresponding NQF number from the National Quality Forum. In this case, the measure falls under one of the 6 national quality strategy domains, specifically the efficient use of healthcare resources. That's important because later stages of meaningful use required providers to cover measures across all 6 domains. For this pharyngitis measure, the National Committee for Quality Assurance, or the NCQA, serves as the steward, and that means that they oversee the official definition of the measure, including the description and the details of how it's calculated, the numerator and the denominator. So what's being measured here, it's the percentage of children ages 2 to 18 who are diagnosed with pharyngitis, were prescribed an antibiotic, and had a group A streptococcus test done before that episode. And the idea is to prevent inappropriate antibiotic prescribing. Too often antibiotics are given for viral sore throats, which don't benefit from them. So this measure encourages providers to confirm the diagnosis with a strep test before prescribing. Now, from a clinical engineering perspective, this example shows just how interconnected these measures are with technology. For the measure to work, the clinic has to use certified EHR technology that can record the diagnosis, capture the lab test, and link it to the antibiotic prescription. If the lab equipment isn't calibrated or if the test results doesn't interface correctly with the EHR, the measure won't be recorded accurately, and that means that the provider risks looking non-compliant, even if they gave the right care. This single example illustrates the broader point. CQMs are aligned across multiple programs, so CMS, NQF, NCQA, and they depend not only on clinical decision making, but also on reliable systems, devices, and data integration. Numerator and denominator in a CQM. To really understand how these clinical quality measures work, let's break down the parts of the pharyngitis example. So every measure has 2 key components, a denominator and a numerator. The denominator is the bigger group and the population we're looking at. In this case, it's the number of children ages 2 to 18 who had an outpatient or emergency department visit with a diagnosis of pharyngitis and who were prescribed an antibiotic within 3 days of that visit. That's our total pool of patients who could be counted. The numerator is the subset of that group who met the quality target. Here, that means the number of those children who actually received a Group A streptococcus test within a 7-day window, 3 days before to 3 days after the diagnosis. So the quality measure is essentially a percentage of all the kids who got an antibiotic for sore throat and how many were actually tested for strep. Now, here's where clinical engineering enters the picture. To calculate this correctly, the EHR has to pull data from multiple places, diagnosis codes, prescription records, and lab test results. If the strep test analyzer isn't connected properly to the EHR, or if the data interface drops results, the numerator might be undercounted, even though the care was done right. And if visit documentation or order entry isn't integrated, the denominator could be inaccurate too. And that's why reliable device integration, validated data capture, and secure information flow are essential. These measures aren't just abstract numbers, they depend on the technology backbone that engineers maintain every day. Hospital quality measure example. Now let's look at an example of a quality measure for eligible hospitals. This one focuses on patients with ischemic stroke. That's when a blood clot blocks blood flow to the brain. The specific measure looks at whether stroke patients are prescribed antithrombotic therapy at discharge. In plain terms, this means did the patient leave the hospital with medication to help prevent future blood clots? Like the professional measures we talked about earlier, the hospital measure is carefully defined and tracked across multiple programs. It comes with a CMS e-measure ID, a national quality form number, and a version number. The Joint Commission is the steward of this particular measure, meaning they oversee its definition and how it's used. And it lines up with the national quality strategy priority of clinical processes and effectiveness. Right? The former description is simple but powerful. Ischemic stroke patients prescribed antithrombotic therapy at a hospital discharge. So, from a clinical engineering perspective, this kind of measure highlights how much depends on accurate documentation and reliable technology. To record compliance correctly, the EHR needs to capture the diagnosis of ischemic stroke, confirm the discharge medication order, and ensure that data is linked properly. If the hospital's pharmacy system or electronic prescribing tool doesn't interface correctly with the EHR, the patient might get the prescription, but the quality measure might not reflect it. On top of that, many stroke patients rely on imaging systems, infusion pumps, or monitoring devices during their stay. If those technologies aren't reliable, they can delay diagnosis or treatment, which may affect whether patients even reach discharge in a condition where antithrombotic therapy is appropriate. So while this measure looks straightforward, it actually depends on a chain of people, processes, and technologies all working together to ensure that stroke patients leave the hospital with the right preventive care in place. Numerator and denominator for stroke measure. Just like the outpatient pharyngitis example we looked at earlier, this hospital stroke measure also boils down to a numerator and a denominator. The denominator is the total number of patients admitted with an ischemic stroke. That's our full population for this measure. The numerator is the subset of that group, the number of those patients who are actually prescribed antithrombotic therapy at discharge. So the quality score here is simply the percentage of stroke patients who leave the hospital with the right preventive medication. Now, for clinical engineers, here's where it connects. To get this right, the hospital's electronic health record system has to pull information from several sources: the diagnosis of stroke, the discharge record, and the medication order. If any of those pieces are missing, or if the data doesn't flow between the systems, the numerator won't be counted correctly. So think about it this way: a patient may receive the prescription in reality, but if the pharmacy system doesn't interface properly with the EHR, that patient could disappear from the numerator, and that means the hospital's quality score would look lower than it really is. And beyond data reporting, engineers also support the diagnostic and monitoring technologies that help identify stroke patients in the first place, like CT scanners or neurological monitors. Reliable technology helps ensure patients get timely diagnosis and the right care pathways, including discharge medication. So, once again, even a straightforward percentage depends on a complex web of clinical processes and technical reliability. MACRA, shifting Medicare to value based care. Now, as I said, let's talk about a major shift in how Medicare pays for care. The Medicare Access and CHIP Reauthorization Act of 2015, otherwise known as MACRA. MACRA is all about moving away from the old model of fee for service, where providers were paid simply for doing more, and toward a model that rewards value and better outcomes. In other words, it's not about how many procedures are done, but about whether patients are actually healthier as a result. One of the big goals of MACRA was to simplify and unify the patchwork of federal quality programs. Instead of providers juggling separate reporting systems like PQRS, value based modifiers, and the Medicare EHR incentive program, MACRA combines them into a single framework. That framework gives providers two pathways to participate. First, there's the merit based incentive payment system, or the MIPS. And MIPS blends elements of earlier programs like the PQRS and meaningful use into one score that's based on four areas: quality, resource use, clinical practice improvement, and the use of certified EHR technology. Second, there are alternative payment models, or APMs, alternative payment models. And these models try new ways of reimbursing providers for Medicare. Some examples include lump sum incentive payments offered between 2019 and 2024 for eligible providers. Higher annual payments starting in 2026 are going to be for those who fully participate. We have greater transparency around physician-focused payment models. So APMs often take the form of accountable care organizations, patient-centered medical homes, or bundled payment models where providers are paid for managing a whole episode of care instead of billing for each piece separately. Implementation has been phased in gradually since 2015, with the intent that by around 2020, the old fee for service model would be largely replaced by would be replaced for Medicare patients. So that leaves MIPS and APMs as the main reimbursement system moving forward. Now, for clinical engineers, MECRA might seem like a policy issue that's more for doctors and administrators, but here's the connection. Both MIPS and APMs depend heavily on accurate quality measurement and certified EHR technology. So that means that data coming from medical devices, lab systems, and imaging equipment has to be correct, integrated, and secure. So if the technology doesn't support accurate reporting, providers can lose reimbursement, even if the care was high quality. So in many ways, MACRA reinforced what we've been saying all along. Quality isn't just about clinical practice. It's about the systems and technology that allow quality to be measured, proven, and rewarded. And just one more point on this slide is that, again, as I mentioned, these may be more on the healthcare giving side, but it's important for engineers and equipment technicians to understand the culture of what clinicians and other healthcare providers have to work with, the environment for which they work with, so that you can better integrate into their systems. So that brings us to the end of part 2 in quality measurement and improvement. So to recap, in this session, we explored how quality is measured across different settings in healthcare. We saw that health plans often rely on HEDIS measures from the NCQA, which focuses heavily on process measures like screening, preventive care, and chronic disease management. We talked about outpatients. So in outpatient settings, they have historically used programs like the PQRS, which reward or penalize physicians based on their reporting of quality measures tied to common conditions and preventive care. We also looked at inpatient settings. So within inpatient settings, they use a variety of measures, but the most widely recognized come from the Hospital Quality Alliance, or the HQA, and include areas like heart attack, heart failure, pneumonia, surgery, asthma. And finally, we saw how one of the core meaningful use criteria for both eligible professionals and hospitals is reporting on a series of quality measures through certified EHR technology. Taken together, these programs show how quality measurement is woven throughout the healthcare system, from the insurance side to the clinic to the hospital bed. For clinical engineers, the lesson here is that all of these measures depend on technology, accurate devices, integrated systems, and reliable data flow. Without the right infrastructure in place, quality can't be tracked and improvement can't be proven. In our next lecture, we'll build on this foundation and look more closely at how quality improvement efforts are implemented, moving from measuring care to actually making care better. So until then, remember, measuring quality is the first step, but improving it is the ultimate goal.